Namaskar everyone. I welcome you all to the second lecture of our series of lectures on the sports injuries of the knee. The second lecture is about mechanisms and classification of soft tissue injuries of the knee. Having studied the anatomy and basic functioning of the various structures in the knee, it is time for us to dwell upon the common soft tissue injuries of the knee. The soft tissue injuries of the knee involve damage to the ligaments, tendon, menisci, cartilage, or surrounding supporting structures. They are commonly seen in sports or trauma, but they can also be seen in degenerative conditions and can be classified as ligamentous injuries, meniscal injuries, tendon injuries, and other soft tissue injuries. The ligaments can be isolated ACL, PCL, MCL, or LCL injuries, or they could be a combination of injuries called the multi-ligament injuries of the knee. The meniscal injuries could be traumatic or degenerative in origin. The tendon injuries could be rupture of the quadriceps or the patellar tendon, or tendinopathies around the knee, which are called jumper's knee or runner's knee. The other soft tissue injuries of the knee could be chondral or osteochondral injuries, damage to the articular cartilage like in chondromalacia patellae. It could be bursitis of different bursa around the knee, or fat pad impediment called Hoffa's disease. Now let's try to cover each of these separately, beginning with the ligamentous injuries of the knee. The anterior cruciate ligament can be injured in various ways, like the contact or a non-contact injury. Here the contact means contact with an opponent. The contact injuries happen when there is a collision with the opponent and there is a valgus force on the knee with the external rotation of leg as shown in the first sketch. In sports, the most common is the non-contact injuries of knee, and this can happen during pivoting or change of direction when the foot is planted, or when there is a sudden deceleration while running as shown in the sketches of the bone. There are situations where the risk of sustaining ACL injuries are higher, like participating in certain sports such as football, basketball, gymnastics, as well as skiing. Poor conditioning or training contributes to these injuries. Wearing improper footwear that does not fit properly, or using poorly maintained sports equipment such as ski bindings, etc., or can also be responsible for these injuries. Using faulty movement patterns such as moving the knee inwards during the squat, and if you are a female, then the possibility of these injuries is slightly higher owing to the differences in anatomy, muscle strength, and hormonal influences. Based on the anatomical location of the knee, of the ligament, of the injury in the ligament itself, the ACL tears can be either avulsions from the tibial attachment or avulsions from the femoral attachment, or a mid-substance tear. The tibial avulsions can be managed like a fracture, but the other ligament injuries require a reconstruction. Let's now talk about the other cruciate ligament injury of the knee, that is the PCL injury. We have already studied that the PCL resists posterior translation of TB. So, the most common mechanism of PCL tear is where there is an excessive posteriorly directed force on the tibia, which can overwhelm the strength of PCL. The common mechanisms of PCL injury are shown in the sketches. PCL can be injured in a dashboard injury, which is generally sustained during a road traffic accident when there is an posteriorly directed force on the proximal tibia due to the dashboard of a car with the knee in a flexed position. Another mechanism is fall on a flexed knee with foot in plantar flexion. This causes hyperflexion of the knee, and this is another mechanism where PCL can be injured. In athletics or in sports, the typical mechanism of isolated PCL tear is a direct blow to the anterior tibia or a fall on the knee with the foot in plantar flexion, as shown in the figures. Football, rugby, and skiing are among the commonest sports where there is the highest incidence of PCL tears. While in the ACL, the non-contact injuries are common, the PCL, because it is much more stronger than ACL, generally gets injured in a contact type of a injury. The patterns of PCL tear can be an avulsion from the proximal tibia or from the femoral attachment or a mid-substance tear. And like in the ACL, the bony avulsions should be fixed like a fracture, but a mid-substance tears may require ligament reconstruction using grafts. We will be studying about the management in detail later. Next in the list is the collateral ligament injuries. The MCL or the medial collateral ligament is injured when there is an excessive valgus stress, as when there is a lateral blow to the knee and the foot is planted, as shown in this figure. MCL tears are often associated with ACL or meniscal injuries. The lateral collateral ligament is injured when there is an excessive varus stress on the knee. That is, when there is a medial blow to the knee. The LCL are most often a part of the posterolateral corner injury of the knee, which additionally involves the posterior oblique ligament and the arcuate ligament complex. Having seen the individual ligament injuries, let's see their classification. There is a common classification system for ligamentous injuries based on their severity. Grade 1 is mild injury, where there are microscopic tears in the ligament but no gross instability. The patient may have a little local tenderness and minimal swelling. However, on stress testing, these injuries are generally stable. A grade 2 or a injury is a moderate or a partial tear injury of the ligament. Here, the tear is incomplete. Some amount of laxity may be present, but on stress testing, the endpoint is generally firm. Pain and swelling is generally slightly more as compared to grade 1 injuries. A grade 3 injury is a severe injury which results in complete tear of the ligament. There is a significant laxity in the ligament with no firm endpoint on stress testing. It generally results in marked instability and is often associated with other injuries of the knee. Having studied the ligamentous injuries, now let's come to the meniscal injuries. The common mechanism of meniscal injuries are twisting or pivoting injury to the knee, where the knee is loaded, flexed, and weight bearing. They can also occur as degenerative tears, and these are generally seen in older patients, and these can happen even without a significant trauma. In general, the medial meniscus is more commonly injured as it is more fixed to the bone due to the attachment to the medial collateral ligament. The meniscal injuries can be classified based on the pattern as longitudinal injuries, radial injuries, horizontal injuries, flap tears, complex tears, and bucket handle tears, as shown in this figure. By the location of injury, they can be classified as injuries to the anterior horn, to the body, or the posterior horn. By vascular zone, they can be classified as injuries to the red zone of the meniscus, as we have studied earlier. This is the most peripheral portion of the meniscus and has good vascularity and good healing potential. It may be in the intermediate red-white zone, or it may be in the white-white zone, which is a poorly vascularized region of the meniscus, and hence the healing is poor. Having studied about various ligamentous and meniscal injuries, I will briefly touch upon a combination of injuries called the O'Donnell's triad or the unhappy triad of the knee. This is a combination of ligamentous and meniscal injuries wherein the anterior cruciate ligament, the medial collateral ligament, and a meniscus is injured simultaneously. This occurs due to side blow to the knee while the knee is planted, and this creates excessive valgus stress and a twisting motion in the knee. The structures on the medial side of the knee get injured easily because of this mechanism. This injury is called unhappy because of the severity of the injury. The nature of combination of injuries results in a long and difficult recovery process, and there is a serious potential for a long-term morbidity and effects like osteoarthritis. This injury, because of its severity, makes return to pre-injury function challenging for an athlete. Next common set of injuries I will be covering are the ones involving extensor mechanism of the knee, that is, either the injury to the patellar or the quadriceps tendon. Generally, a forceful contraction of quadriceps during fall or jump, or a sudden eccentric contraction of quadriceps during forced flexion of the knee may be responsible for these injuries, as shown in this figure. Sometimes direct trauma to anterior aspect of knee can also result in these injuries. The quadriceps and patellar tendon injuries can be classified based on the severity or damage to the tendon as partial or complete tears. Partial tears, as the name suggests, means only a few fibers are damaged, and complete means the whole tendon is damaged. Complete tears result in significant disability, that is, loss of extension of the knee, and generally requires surgery, whereas partial tears can be managed non-operatively. Based on the underlying pathology, the injury can be a tendinopathy, a strain, a contusion, or a laceration. There is an entity called jumper's knee, which is patellar tendinopathy, and this occurs near the lower border of patella. And this is generally a result of chronic overuse in long distance runners. The usual causes for these injuries are, as I have already said, forceful eccentric contraction of quadriceps, as seen in jumping, sprinting, and kicking. Direct trauma, as seen in falls, or blunt injury to the knee, or lacerations, or penetrating trauma to the knee, as when it happens in road traffic accidents. Degenerative changes due to aging, overuse, or systemic diseases can weaken the tendon and predispose to such injuries. Weakening of tendons can also happen because of long-term use of drugs like corticosteroids or fluoroquinolones, and this also predisposes these tendons to injury. The next common entity is the injury to the medial patellofemoral ligament, or the MPFL. The MPFL is a primary restraint against the lateral patellar displacement. It keeps the patella and trochlea. Injury to this ligament typically occurs due to acute traumatic patellar dislocation, which is the most common cause, or indirect trauma like sudden twisting or pivoting of the knee with the foot in a planted position, or sometimes due to direct blow to the medial side of patella, which pushes the patella laterally. It may result in recurrent dislocation of patella or patellar instability and may require surgery for stabilization. Finally, we look at the miscellaneous or other soft tissue injuries of the knee that can cause significant symptoms and disability. First among them is the anterior fat pad impingement or the Hoffa's disease, which is a painful condition of anterior knee caused by the pinching or inflammation of the infrapatellar fat pad. This fat pad is located between the patellar tendon and the anterior aspect of tibia. This condition may result from trauma, repetitive stress, or other structural issue leading to inflammation, swelling, and fibrosis of the fat pad. The symptoms include anterior knee pain, especially with extension of the knee. There may be local swelling, restriction of knee movements. Next is an entity called chondromalacia patellae, which is essentially the softening of patellar hyaline cartilage. It is also known as runner's knee because it affects many athletes and active individuals. Causes for softening of the cartilage can be a patellar malalignment, which is the most common cause. In this, the patella does not slide smoothly over the trochlea, leading to abnormal stresses on the cartilage. Repetitive stresses from activities like running as well as direct injuries to the patella can contribute to this problem. A weak or tight muscles which balance the patella, leading to imbalances in the muscle supporting knee, can also cause patella to shift out of alignment, leading to degeneration of its cartilage. Last but not the least is a condition called bursitis, which is inflammation or swelling of various bursae around the knee. The bursa are thin, fluid-filled sacs located normally in high friction areas around the knee. They help in cushioning and lubricating the structures like tendons, ligaments, and muscles, and thus enable smooth and pain-free movements. They may be inflamed and cause pain, swelling, tenderness, and local increase in temperature. It often results from activities like kneeling, repetitive pressure, trauma, and in some cases due to an infection or inflammatory conditions like gout, rheumatoid arthritis, and degenerative conditions of the knee like osteoarthritis. Baker's cyst is a commonly seen bursitis in osteoarthritis of the knee. It is an enlargement of popliteal bursa and seen in the popliteal fossa that is behind the knee. Prepatellar bursitis is the inflammation of bursa in front of the patella and is also known as housemaid's knee, and this occurs due to repetitive kneeling on the knee. Pes anserine bursitis is seen about 2 to 3 inches below the medial joint line on the medial side of proximal tibia, and this happens around the insertion of the medial hamstrings on the tibia. Clergyman's knee or infrapatellar bursitis is the inflammation of bursa located just below the kneecap. Having touched upon the various soft tissue injuries of the knee, let me summarize them briefly. The soft tissue injuries of the knee can result either from direct or indirect injuries or repetitive injuries, and in some cases due to infection or degenerative conditions. These can involve any soft tissues around the knee like the ligaments, menisci, the tendons, the cartilage, fat pad, and bursa, and cause various degrees of damage resulting in a degree of disability which is usually proportional to the severity of the injury. This brings us to the end of this lecture. I hope the concepts about the mechanisms and classification of injuries of various soft tissues around the knee are clear to you all. Thank you and Jai Hind.